Hi everyone, this is Neel Raithatha, consultant audiologist and director of Clearwax. Thank you for joining me in my latest video where I actually have two procedures and I've grouped them together because they have a common theme, which is quite narrow, bendy, but more so very hairy ear canals at the entrance. Now, this is patient one and this is their right ear, and initially this wax is quite deep, so the hairs are not really problematic because the endoscope goes past the hairs. But as we retrieve this wax from the deeper part of the ear to the entrance, the hairs begin to obscure the view slightly more. Now, it doesn't affect myself doing the procedure, but I know it can affect the view when you're watching it. But I wanted to share these because I think it's important, because I've had loads of other specialists contact me really struggling with hairs when they perform earwax removal. So this is it can be challenging sometimes depending upon which technology you're using to remove earwax. But in the past, I was very reluctant to post videos with hairs because unfortunately you do get a bit of abuse sometimes. Now, some of the questions I've had from specialists is, what can you do with the hairs? Now, sometimes it can be difficult because there's not much you can do. So in terms of trimming hairs, I have tried different techniques. I've tried kind of these little mini scissors that are curved and it's got a blunt nose, so it's not sharp, but it's really difficult to cut the hair, because these hairs, they may look like they are outside the ear, but they're not. They're actually inside the ear, and the ear canal is really, really narrow. So it's not really easy to cut the hairs in a small cavity like this, even when you illuminate it. There are also some forceps, so the same forceps that we use during the procedures, microjaw forceps that are scissors, but again, they only cut like a few hairs at a time and you'll be there forever. If you're using a specular, one technique could be, when you insert the specular, you rotate it and you can get some of these hairs out of the way. But I've plucked hairs in the past. I generally don't remove the hairs because it doesn't really, I can manage with them. But in one or two cases I've had over the years, there's just been so much hairs that I've had to pluck some of those. And even that, it didn't completely make the view clear. It did help it enough for me to perform the procedure. Now, I've also tried an electronic trimmer. And what we're trying to do is kind of contain, I don't want these hairs flying around in the room. These kind of collect some of the hairs as well, but they just weren't very good once more. And the people I tried it on said that the trimmer got really hot as well. And with all of these things, there are also sterilization issues as well. So some of the forceps, scissors, you kind of autoclave them, which basically means you can reuse them, but it is a tricky one. One of the other techniques is to use a smaller specular, so it goes, if you're using a speculum, so you can go a bit deeper in the ear and kind of push some of these hairs out of the way. But the specular only goes 1/3 into the ear, so some of these hairs can actually, although they should terminate in the outer third, the cartilaginous portion, because you shouldn't really have any hairs growing on the bony part of the ear canal, because you don't have the middle layer of skin, the dermis layer where the hair follicles are. But sometimes people can have extra long ear canals. Even the specular, it doesn't go 1/3 of the way in. So some of these hairs can be protruding from the tip of the specular. But as you can see, we're managing. I know for viewing pleasure, it's not great, but it's something that a lot of specialists do ask questions about. And so one of the great things about the endoscope is, if the wax is deeper with the endoscope, you just insert the endoscope past those hairs. So for deeper wax, it doesn't really matter if you've got hairs at the entrance, because you're going to go through that. But when you've got hairs near the entrance, the endoscope is having to I can't not put the endoscope in the ear. It has to go in the ear so I can visualize the wax. And sometimes the hairs are there. I can't move the endoscope any left, right, or center. It has to be in that position. So you can see there's a few hairs there, but I found a gap in the middle, so I'm working around that, and I'm going to the roof. So you just got to work around it. But yeah, it can be challenging at times, but when you remove earwax, these are the things that you have to deal with and get used to. And ultimately, it's just practice, and the more you do it, the better you'll get, like with anything, really. So now that I brought some of this deeper wax forwards, you can see that the hairs are just there. And the hairs are normally, the predominant hairs are around the first bend, where we're just curled around then. So although the entire outer third of the ear canal should have hairs, it's the hairs just around that first bend. They protrude outwards. The hairs in the deeper part of the outer third, they're more horizontal. They lay more flat against the canal wall, so they're less problematic. So you can see this deeper wax is quite a lot more stubborn. Now, this particular video, I could swear to myself that I did previously upload this. I remember this video because it was performed on a day where I had my niece. You may have I've mentioned it in some other videos. My niece came in to observe me in clinic, and this is the first patient that she saw, which was really good actually, because it was quite a difficult one. And I had sworn I had uploaded it, but I just looked through some of my videos and it's not uploaded. So I apologise if it has been uploaded already and I've missed it. But I treated this patient on the 30th of August, and I just looked through my timeline on YouTube and Facebook, and I can't see this video anywhere. So we're just bringing this wax forward, and they have got a narrow bendy ear. This wax is quite firm. You can see it's quite dark. It's very solid. So I am using a combination of the ear hook and also the correct thing with the ear hook. Now, this is the right angled ear hook, because it's got this tapered tip and it's streamlined. I can really, even if the wax is right up against the canal wall, I can glide in there, which I couldn't do with the previous ear hook that I used. So this is an intentional design. And what was interesting with this one is this patient is, once I cleared the wax and visualized the eardrum, I asked my niece, because she's an audiologist student, what they thought of the appearance of the eardrum, because it's slightly different, and that's because the pars flaccida region of the eardrum was more pronounced. So the eardrum can be subdivided. You get the pars tensa, which is the main body of the eardrum, and that typically runs from around, say, 1 o'clock all the way around to about 11 o'clock. And that's the tense part of the eardrum. That's where the middle fibrous layer of the eardrum, so the eardrum is 3 ply thick. The outer layer of the eardrum is lined with the epithelial skin that lines the inner 2/3 of the ear canal. The innermost layer of the eardrum is the mucosal skin, which lines the middle ear. And the mucosal skin is similar to the skin that lines the inside of our nose and mouth. It's more secretory, it's wet and sticky. Then you have a middle fibrous layer. And in the pars tensa region, this fibrous tissue is very well organized and arranged. In fact, there's 3 arrangements of this fibrous tissue. You get a concentric arrangement. So you get these round circles of fibrous tissue which overlap each other. Then you get a radial arrangement. So it's from the center of the pars tensa, the fibrous tissue extends outwards from the center to the edge of the eardrum, and combine the radial arrangement and the concentric arrangement mimic a spider's web. And then you have a third arrangement, we call that parabolic arrangement, where you get these kind of oval, round arrangement. But nevertheless, the middle layer of the eardrum is very taut and tense, hence the name pars tensa. Now the top part of the eardrum, now here it's about 10 o'clock to about 2 o'clock. You can see the posterior malleolar fold and anterior malleolar fold. You can see that top part just looks thinner. Now in fact that part of the eardrum is not thinner, but it's called the pars flaccida. It's more elastic, and the reason for that is that middle fibrous layer in that region of the eardrum, the fibrous tissue isn't well organized. It's more dispersed and irregularly arranged, and it makes it more elastic. In actual fact, it's actually thicker, believe it or not, than the pars tensa. But yeah, in a normal eardrum, I'm not saying this is abnormal because the patient hasn't got any pathology, but it was quite an interesting one for my niece to see, because it just looks a bit different. It's more obvious, the pars tensa and the pars flaccida. You can see that horizontal line near the top of the eardrum from left to right, and that top part, you can see it looks thinner, but it's not, it's more elastic. You can see the difference in consistency there. So we just mopped up now. There's a bit of surface wax around the edge. We're going to leave all that if anything comes away, but the ear canal's clear. That's what we're trying to obtain there, and the patient can hear again. Now, this one is a lot more hairier, but again, I kind of manage. As we get deeper in the ear, these hairs become less problematic. But again, I can't put the endoscope any further in, because if I do, I'm right up against the wax. I can't take it out any further because I don't get the view. So you can see at the bottom, this is kind of matted. And this patient's ear canal, there was a bit of edema, a bit of swelling, so they did get some water inside there. And this last plug is really impacted on the eardrum, so it was a bit of a challenge to remove. And another difficulty with this one is particularly the wax that I'm removing now. It's not too dissimilar in colour to the canal wall. So especially on the left hand side, so that's on the screen it's left, but that's the front part of the ear canal, the anterior canal walls, it's the left ear. I've got to judge where the ear canal is, because it kind of almost blends in and camouflages this wax up against the canal wall. So I'm giving it these little wriggle movements. I think I put some drops in a bit later, and that really, really did help. So it's generally men that have hair ears, and that's because the hairs around our ears are actually not sensitive to testosterone until later on in life. And of course, men have more testosterone than women. So there comes a certain point in a gentleman's life that the hairs around the ears, they become sensitive to testosterone, which causes thicker growth. Unfortunately, testosterone on the crown region or temple region, it gets converted into dihydrotestosterone in men, and that's the underlying cause of male pattern baldness. There's an enzyme that converts testosterone into dihydrotestosterone. I think it's alpha-5 reductase or something like that. And essentially, when testosterone converts into dihydrotestosterone, it miniaturizes the hair follicles, particularly in the crown region and temple region, which then causes a miniaturization of the follicles, as I mentioned, and the hair just gets thinner until the follicles die. So yeah, as we grow older, as men, we grow hair in places we don't want to, so around the ears and the nostril region, but we struggle to grow hair in the regions that we desire. So you can see this last bit of wax deep in it. It's really, really large. It's got this softest consistency, so it's, you couldn't use forceps because it will just cut away at it. Using manual instruments, I try and avoid if it's this deep, if possible, if there's alternative ways. Sometimes we just have to use the manual instruments. You can see the camera's got slightly blurry because there's a few hairs there, but again, it's not really impacting what I'm doing, so I'm still comfortable in the view that I've got. But yeah, I can appreciate for viewing pleasure. It may not be the greatest, but the view does improve a bit later because I'm able to put the endoscope a bit further in the ear. So just put some oil in. I'm trying to go through those hairs, as you can see. So if I can get the endoscope in that gap. So I'm just trying to leverage this down from the roof of the ear canal. There's a bit of wax there. You can see it's coming away. But when it's matted like this, it's always much more tricky because it's harder to get a suction grip. I'm really tugging away at this. And whilst we're doing this, we've got to just make sure we don't make contact with the canal wall, because when we work in the inner 2/3, that's the bony part, that's where it's really uncomfortable. So I think this patient, if memory serves me correct, they did use a Q-tip, and they owned up to it straight away. They fessed up to it. They didn't. It's important for me to know that if you have used a Q-tip and pushed this in, because it gives me an idea of the complexity of the procedure. Whenever someone uses cotton buds, 9 times out of 10, it's going to be a complicated procedure, and there's just increased risk of pain. And most of these patients attend with pain, because when you push something right deep against the eardrum, it's going to be uncomfortable, and you may have caused some swelling. But if you do come to visit me and you have used a kit, just let me know. I'm not going to, I don't bite, but I will give you like a, not telling off. If I do, it's kind of in a jovial, jokey way, but I just explained the risks of using cotton buds and why we shouldn't really. So, but do tell me if you do. It's important for any specialist that you see that you do let them know. So you can see the back part of the eardrum, but this is really large now. So although the patient's hearing was significantly better, I want to get this remaining wax. And here is the inferior recess. So you can see the angle of the suction probe is going down. We're trying to go into that recess. So just got a bit blurry there. That's because of the oil. I put a lot of oil in. When you suction oil, it can get blurry. So I just pause momentarily, just suction out some excess oil. And then we're going back in. So it's going to wipe the lens, trying to get through those hairs. And just going to lift this up, but it is impacted. See, the hair's less problematic now because I can position the endoscope past those hairs. I've got a good suction grip. I can just sense that by watching it. And I'm going to lift it up. And there's a thick layer of skin surrounding this plug of wax. And I don't want to lose this grip. I'm going to just keep teasing this slowly in little circles. If I come away with the suction probe too quickly, I lose that airtight seal and I lose suction power, but I've got a good grip now. And you can see that thick layer of skin, and we've lifted that away from the inferior recess. That's the patient's eardrum, so there's a bit of residual wax staining the drum, but that's fine. Eardrum's nice and healthy. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.